Good morning, everyone. Today we'll be discussing advanced HIV disease. And the basic pathogenesis of HIV is the depletion of CD4 lymphocytes, which is the primary coordinator of the immune system. While the body can replace destroyed CD4 cells over time, this ability is progressively degraded, leading to a decrease in the number of circulating CD4 cells, decreased immune function, and it makes the body susceptible to infections. And these infections, we call them opportunistic infections because they occur at the lowest ebb of the body's immune system. They don't usually come to an immunopotent individual. Okay, while this progressive immune damage usually causes symptoms, often these symptoms go unnoticed and the person is going about with opportunistic infections and very low CD4 counts. In the picture at our right-hand side is a pictorial demonstration of what happens in advanced HIV disease. At onset of symptoms, at onset of the infection, the the virus marked in red, there's a rapid increase in the multiplication of the virus in the body, leading to a decrease in the blue line, that's the CD4 cells in the body. So with time, the body tries to generate CD4 cells, and this brings down the virus, the viral load, marked as red. But with prolonged period of time, especially in the face of malnutrition, other things that can give you immunodeficiency, the body is not able, and of course, with the multiplication of the virus and the destruction of the CD4 cells, the CD4 cells is markedly depleted, leading to a continuous rise in the virus. And eventually what we see is a manifestation of AIDS defining criteria. That's the acquired immunodeficiency syndrome. And those symptoms are characterized by manifestations of various opportunistic infections. HIV-related mortality is as a result of opportunistic infections. These include tuberculosis most commonly, and fungal infections like the cryptococcal infection. We notice from this chart that tuberculosis causes about 35% of HIV-related mortality. You also see pneumocystic carina pneumonia, which is now called pneumocystic jirovecii pneumonia, causing at least 15%, and toxoplasmosis, severe bacterial infections that ordinarily may not be severe in immunopotent individuals. But because these ones are immunodeficient, they come down with HIV-related mortality. Of course, with the cryptococcal meningitis that is also seen. What is WHO definition of advanced HIV disease? For adults and adolescents and children older than 5 years old, advanced HIV disease is defined with CD4 as criteria. CD4 T lymphocyte cells less than 200 cells per millimeter cube, or WHO clinical stage 3 and 4 events. Also, all children younger than 5 years of age with HIV are considered as having advanced HIV disease. That picture you are seeing, the child is malnourished, the child, of course, immunosuppressed with different kinds of opportunistic infection. This child can go for child with TB, child with severe bacterial infection. It's a whole group of infections that can invade an individual that is immunosuppressed. There's an advanced HIV disease package for hospitalized patients. We know that people that have advanced HIV disease are not people that you manage as outpatients. You give them oral medications to go home. No, they must be investigated so that diagnosis can be made, prophylaxis can be given, or presumptive therapy where it's available. Then, of course, treatment where diagnoses are made. And of course, these people need adapted adherence support. So for diagnosis, I've told us that CD4 lymphocyte cell is used as criteria for making diagnosis. We also have cryptococcal antigen, blood or CSF, that's cerebrospinal fluid analysis, where you are looking for the antigen of cryptococcus. Okay, if found, it means the person has cryptococcal meningitis, especially when found in the CSF. Tuberculosis lipoarabdomanam is also an antibody test used to antigen test, used to diagnose TB, is a urine antigen test. GeneSPAT is also an antigen test used for diagnosis of TB. We want to make diagnosis of opportunistic infection so that we can treat to avert deaths resulting from opportunistic infection. Okay, we had talked about CSF from lumbar puncture. That's where we get CSF that we will use for making diagnosis of cryptococcal antigen. Also, hematology and chemistry. Remember, we said severe bacterial infection can also be a cause of AIDS-related mortality. Preventive or prophylaxis or preemptive treatment. For tuberculosis, we have what we call tuberculin preventive therapy. Here, commonly, we use the isoniazid to prevent TB. If we had looked at the child or the adolescent or the adult and it doesn't have clinical features suggestive of TB, we can prevent, because we know that TB causes as much as 35% of AIDS-related death. Fluconazole is a prophylactic treatment for cryptococcal meningitis. Cotrimoxazole preventive therapy prevents against pneumocystic jirovecii or pneumocystic carrier pneumonia, toxoplasmosis, and other systemic fungal infections. Intensive adherence counseling. These are the people that have this advanced HIV disease need intensive adherence counseling on medications so that they don't stop and start, because when drug resistance develop, they may be very difficult to combat. And of course, they need community support, social support from friends and family. Then the treatment of people with advanced HIV disease needs clinical expertise. You have to be able to make a diagnosis. If cryptococcal meningitis is made, appropriate treatment is instituted. If tuberculosis is made, treatment is also instituted with a fixed dose combination of 4 commonly used drugs. And of course, other opportunistic infections are also considered. And if diagnosis is made, treatment is started as appropriate. Appropriate antiretroviral timing is also very important and crucial, because for people with opportunistic infection with comorbidity with HIV, we don't rush to start antiretroviral drug. We first of all manage the opportunistic infection, because the opportunistic infection can easily kill the patient far better than the HIV the person has always had. Okay, but there's timing. We don't rush to start 2 of them together because of what we call complications of IRIS, that's immune reconstitution inflammatory syndrome. So for TB, we use a range of 2 to 8 weeks. 2 weeks when the CD4 T cells at presentation or at diagnosis is very low. The earlier we start HIV after we have commenced anticox for TB, the better. Okay, for cryptococcal meningitis, as long as 4 to 6 weeks we give after we have started treatment for cryptococcal meningitis before we introduce antiretroviral therapy. So what is the take-home message for advanced HIV disease? Advanced AIDS-related deaths are not decreasing, commensurately with increased ART coverage. You know that in Nigeria, the ART coverage has increased tremendously, but we don't see a commensurate decrease in AIDS-related deaths. The AIDS advanced HIV disease is a major cause of death among people living with HIV. The commonest cause of this mortality in advanced HIV disease patients include tuberculosis and cryptococcal meningitis. Advanced HIV disease is defined as CD4 cells less than 200 cells per millimeter cube, or WHO clinical stage 3 and 4, or child living with HIV less than 5 years. Interventions required for advanced HIV disease include diagnosis, treatment, prophylaxis for opportunistic infection, rapid ART initiation, and intense adherence